Good day, everyone. Welcome to our four-part new diagnosis workshop series. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson Society, BC, and I'll be facilitating our workshop today. Today, for our first talk, we have Dr. Jonathan Squires speaking on Parkinson's disease, etiology, diagnosis, and symptoms. Before I introduce Dr. Squires and pass it over to him, I'd like to go through a few housekeeping items. First, I'd like to let you know that we are recording the webinar and it will be posted on our website along with the presentation slides. Secondly, you will see a chat icon at the bottom of your screen. If you click that icon at the bottom of your screen, the chat box will open up. And feel free to use that chat box during the webinar to make any comments or questions for Dr. Squires. There's also a raised hand function. If you press that icon, you can verbally ask your question at the end of the talk. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume, both on your computer as well as on your actual speaker, so that you can hear the webinar well. And if you're experiencing audio issues, please ensure that you haven't pressed your mute button on your keyboard. I'd now like to welcome Dr. Jonathan Squires from the Movement Disorders Clinic at the UBC Center for Brain Health. Dr. Squires, thanks for joining us today. I'll pass it over to you now.
Great, thanks, Elena. Hi, everybody. I'm just going to pull up my slides here. This is the first of 4 talks in this series. So this is a just overview of Parkinson's disease for people who have been recently diagnosed. So you're going to be hearing from me today, Dr. Raston, one of my colleagues tomorrow, and then parts of members of our allied health team in the next couple of sessions around Parkinson's disease. So this is the outline of the overall workshop series. My job for you today is to introduce Parkinson's disease, how common it is, what we know about what causes it, how it's diagnosed, and what the symptoms are. Dr. Raston is going to bring you through the treatment of Parkinson's disease, and then our wonderful allied health colleagues are going to work through the Living Well with Parkinson's section, so I'm going to be taking you down to here today. Feel free to write any comments or questions in the chat as we go along, and I'll try to answer as many as we can at the end of the talk. So first of all, Parkinson's disease has been around for a long time. So this is Dr. James Parkinson, who gave his name to the condition. This essay on the shaking palsy here was published all the way back in 1817. And that was Dr. Parkinson's observations of a few people he'd seen sort of shuffling through the streets of London. So it was the first time that this disorder was characterized. So it's not new, been with us for a very long time. So what is it? Parkinson's is a member of the family of neurodegenerative disorders. So that family also includes other things like Alzheimer's disease, ALS, that sort of thing. The common factors of all neurodegenerative disorders are that certain populations of cells in the brain are slowly dying away, and all of them are characterized by an accumulation of an abnormal protein somewhere in the brain. And what the protein is and where it builds up differs from disease to disease. In Parkinson's disease, we talk a lot about loss of the type of brain cells that make a neurotransmitter, a chemical messenger called dopamine. And the abnormal protein that builds up is called alpha-synuclein. And in Parkinson's disease, it forms these structures that you see under the microscope that were called Lewy bodies, after Dr. Lewy, who first described them. Dopamine, as I mentioned, is a chemical messenger. So brain cells use different chemical messengers to talk to each other, and different networks in the brain that serve different functions use different combinations of these neurotransmitter messengers. And dopamine, specifically with respect to Parkinson's disease, is really important for the control of movement, particularly choosing and sustaining movement. And mood. Also has many other functions, functions in the reward pathway in the brain. So when we do something pleasurable, we get a release of dopamine, which gives us some of that sort of nice feeling when we do something that we enjoy doing. Okay, so what causes Parkinson's disease? Still more than 200 years after Dr. Parkinson first described it, the reality is we still don't really know for most people what causes Parkinson's disease. We do know that somewhere around in the ballpark of around 10%, some studies say 5, some say 15. The numbers are a little bit variable, but say around 10% ballpark are caused by genes. There are genes that we know cause Parkinson's disease, and there are a few genes that increase the risk of Parkinson's disease. Now, in general, people with genetic causes of Parkinson's have younger age of onset, and just rule of thumb, the younger you are when symptoms start, the more likely it is to be genetic. And usually we'll have a family history. It's a little bit complicated though, because there are, like many genetic things, there are different types of genes. So some of them are what we call dominant, where you only need one copy of the gene from one parent. And usually those ones have family history. Some of them are what we call recessive, where you need one copy of the abnormal gene from each parent. And it's relatively unlikely that you would have a family history in that case, because it's unlikely that multiple generations would have multiple people contributing to that, because these are pretty rare. And the really young onset ones tend to be recessive. So there are exceptions, but most of the genetic ones are younger age of onset. Now, we don't know what causes it, but we do know a lot of risk factors for Parkinson's disease. So the most important risk factor by far is age. So Parkinson's disease affects 0.3% of the overall population, but it affects about 1% of people over the age of 65 and 3% of people over the age of 80. So that's number one risk as we get older. Men, for reasons that aren't well understood, are more likely to get Parkinson's than women. So it's about 2/3 of people with Parkinson's are men and 1/3 are women. Having recurrent head injuries over time, so concussions, not little bumps to the head, but actual concussions over time increases the risk. So boxers, soccer players, football players, professional athletes, that sort of thing are at higher risk. For some reason, living in the countryside, people who live in the country are at higher risk of getting Parkinson's than people who live in the city. That may be a variety of things. It may be agricultural chemicals like pesticides, potentially heavy metals in the groundwater. Drinking from a well is a risk, or another risk factor for Parkinson's disease. So it may be sort of metal exposure or something else in the groundwater that's implicated. Family history on its own. So aside from the genetic stuff we talked about, if you have one first-degree family member, so sibling, parent, a child, less likely, your personal risk of Parkinson's is 2 to 3 times the baseline population risk. So 0.3% of the population has Parkinson's. If you have a parent who's affected, 1% basically is your risk. So 2 to 3 times sounds scary, but when you consider that only 0.3% of people will get it in the first place, it's not that big of an increase. And that that family risk either reflects some kind of risk gene that we haven't figured out yet, or potentially environmental exposures. Family members tend to live in close proximity, and they get exposed to similar environmental factors over time. So it's not entirely clear what that's all about. So like most things that we don't understand, we kind of assume that there's some combination of genetic factors, either causative or predisposing to Parkinson's disease, with certain environmental exposures that maybe they occur at certain critical times. And the combination of all of this comes together to cause Parkinson's disease. Okay, so epidemiology talks about how common things are and who is affected. So Parkinson's disease is the most common neurodegenerative disorder after Alzheimer's disease. We estimate probably now the number is probably closer to about 15,000 people living with Parkinson's disease in British Columbia. These numbers are a bit outdated. And similarly, more than 100,000 people in Canada currently living with Parkinson's. And you can see here, this is BC data that again is a bit this is Canadian data. It's about 10 years old, but the pattern will not have changed much. So you can see that as the age increases, the prevalence, which is how many people are living with Parkinson's, really increases over time. Yeah, and very rare before the age of 50, but then picks up quickly from there. So how do we diagnose Parkinson's disease? So it turns out that in 2023, Parkinson's is what we call a clinical diagnosis. So there is no diagnostic test that I can order that will determine with any accuracy whether you have Parkinson's disease or not. The only way to make a definitive diagnosis of Parkinson's disease is actually to do an autopsy, which in my experience has not been a terribly popular option for people. So it's clinically diagnosed based on the history that you provide when you see your doctor, so the symptoms that you're experiencing and things that we identify when we examine you. So the first step is to determine whether you have Parkinsonism. And many of you may have heard this term Parkinsonism and might be a little bit confusing to you. So what Parkinsonism is basically a description of a group of symptoms. So Parkinsonism is some combination of slowness of movement, and the technical movement for that is bradykinesia, which is Greek for slow movement. Bradykinesia is really the defining feature of Parkinson's disease. So if you don't have bradykinesia, you do not have Parkinson's disease by definition. And we'll come back a little bit to what bradykinesia is, but basically slowness of movement. So in order to be diagnosed with Parkinsonism, you must have bradykinesia and rigidity, which is an increase in muscle tone. So when your doctor kind of moves your arms and legs around like this, we're checking your muscle tone to see if there's resistance to passive movement, and that's called rigidity when there is. And or a resting tremor. So if your arms or legs are completely relaxed, you're resting your arm on a table or in an armrest and it starts to shake and then may go away if you move your arm, that's what we call a resting tremor. And so that is also seen in Parkinson's. So you need bradykinesia and rigidity or resting tremor to be labeled as having Parkinsonism. And then the job of the neurologist really, when you have Parkinsonism, is to figure out what's causing it. So Parkinsonism is the symptoms, and then Parkinson's disease is the most common cause of Parkinsonism, but it's a little bit complicated. So what we have to do then is to try to rule out other things that aren't Parkinson's disease that may be causing those symptoms. So again, we sort of talked about this a little bit, and we'll come back to some of that stuff in a second. As I said, the only test to confirm the diagnosis is an autopsy. Imaging studies like MRI and CT scan generally are normal. Sometimes they may show a bit of shrinkage of the brain more than you would expect for your age. And that reflects the fact that certain brain cells are dying away, and so the brain will slowly shrink. And that happens to all of us as we get older, but it happens more quickly than you would expect if you've got something like Parkinson's. There are functional imaging studies, so PET scans that can label dopamine, a DAT scan, which labels a structure that transports dopamine. And this one, just in the last year or two, we've been able to do in Canada, though it's been around for a long time. The DAT scan isn't usually necessary, and it's actually no more accurate than being assessed by a movement disorder neurologist. So we really only do a DAT scan if we don't think you have Parkinson's disease, basically, and we're trying to convince ourselves that that's true. So if it's not Parkinson's disease, then what the heck is it? So it could be a number of different things. Most commonly, if you have Parkinsonism, but not Parkinson's disease, the second most common culprit is actually certain medications that can cause similar symptoms. Those medications are usually psychiatric medications, neuroleptics, the family is called, or antipsychotic medications that work by blocking dopamine receptors. So we're not really smart enough to target the dopamine receptors that are affecting mood. And so there's some like innocent bystander effect where the dopamine receptors that target movement are also blocked, and that causes similar kinds of symptoms. Other medications, like a couple of anti-nausea medications, Maxaran or metoclopramide and Stemetil, or I'm forgetting that, completely blanking on the generic of that one, but it's almost never used. Those, if used chronically, can cause Parkinson-like symptoms. And then a few other medications here and there rarely can cause Parkinsonism. Good news is if it's drug-induced Parkinsonism, it goes away if you stop the drug. And then more importantly, there's another group of neurodegenerative disorders that can very closely mimic Parkinson's disease. And it's important because those diseases, while they're very similar, they tend to progress more rapidly and they don't respond very well to treatment. So those are not things that we enjoy diagnosing. Fortunately, they're uncommon. And how we do, and then just finally, by far the least common is if you have a lesion in your brain in just the right spot, you could end up with Parkinson-like symptoms affecting the opposite side of the body. So something like a stroke or a tumor compressing in just the right spot. That is very rare. I've actually never seen that happen. I've heard of one case that one of my colleagues has with a cyst compressing that structure where dopamine is made in the brain. But usually when we examine you, there's other abnormalities that are caused by that lesion, whatever it is. So that bit is very rare. So what we do when we assess people is we look for what are called red flag features. So symptoms that we either don't expect to see in Parkinson's disease, or symptoms that may be seen in Parkinson's, but not until later. And when we start to see these red flag features, it makes us worry that maybe we're dealing with one of these other neurodegenerative disorders that mimic Parkinson's disease. And the challenging thing is that for the first several years, 3, 4, 5, 6 years, they can be completely indistinguishable even to the best doctor in the world. So we're always keeping an open mind about what the diagnosis is. And that would be things like frequent falls in the first few years, urinary incontinence, cognitive problems, hallucinations, which are all things that can happen with Parkinson's, but usually tend to happen much later. So we're always on the lookout for these red flag features. So how accurate is the diagnosis? So the data here is a little bit murky as well, but if you look at what's out there, we get the diagnosis of Parkinson's disease right about 70–80% of time in the first years of the disease. And then the other people who don't have that have one of those mimics that we talked about. So as I said, we're always on the lookout for these red flag features, and it becomes clear. The Mayo Clinic years ago did a study looking at this question where they actually started off with autopsy results. So they knew exactly what people had, and then they looked back in their records and to see what did we think people had. And in that study, in the early first couple of years of symptoms, they got the diagnosis wrong about 30% of the time. And by the time those people passed away, they still had the diagnosis wrong 10% of the time. And most of those people had one of these mimic disorders, most commonly a condition called progressive supranuclear palsy, which is the closest mimic that can fool you the best. So even with every test at your disposal, the diagnosis is still inaccurate. I guess the silver lining in there is that when you have Parkinsonism, we kind of use the same drugs to treat the symptoms regardless of what the cause is. But still, obviously, it's nice to know exactly what you're dealing with. People often worry about how things will progress. Parkinson's, like other neurodegenerative disorders, unfortunately is a progressive condition. And one of the most common questions that I get asked is, what are things going to be like in 5 years, 10 years, what have you? How are things going to go? It's very difficult for us to say with any certainty because every individual with Parkinson's is different. In general, Parkinson's disease progresses slowly, so we're talking about years and not months here. People can remain stable for long periods of time. One of my mentors used to tell people, yes, this is a progressive condition, but you still have to floss because you're going to be around for a long time yet. Women in general progress more slowly than men. In general, people with younger onset progress more slowly than people with older onset, though none of these things are hard and fast. In general, people with a lot of tremor progress more slowly than people without tremor, but none of these are absolutes. Parkinson's, as I said, always progresses slowly. If there is a sudden worsening of your symptoms, like you wake up one morning and it's like, God, I feel like 5 years of progression just happened overnight or over the span of a week, that's not the Parkinson's disease. That's usually a warning sign that something else is going wrong. And it can be something as simple as having a bladder infection or being under a lot of stress or being super constipated. Any other thing that stresses your body, whether it be a medical problem, psychological stress, will kind of exacerbate the symptoms in the moment. So usually when people call us up and say, oh, my medication's not working anymore, I'm so much worse, the first thing we do is say, well, you should go see your family doctor or a walk-in clinic and have your urine checked, have some blood work done, make sure there's not some other medical problem going on. because it's not likely that your Parkinson's is going to be like that. And then in general, the rate of progression for a given individual doesn't really change. So if you're progressing sort of along this trajectory, so very, 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 very slowly, you're not going to suddenly drop off a cliff like that. It's going to keep going along that line. Similarly, unfortunately, if you're going along this trajectory, which is not that common, fortunately, it's likely to stay about like that over time as well. In general, the best predictor for your future is your past. So the rate of progression you've seen over the last 2, 3, 5 years is about what you're going to see over that next 2, 3, or 5 years. So we've talked a little bit about how it's diagnosed, how common it is, but what does it even look like? What symptoms do you have? If you've been talking to other people with Parkinson's or reading about symptoms of Parkinson's, you've probably realized that the common theme is that there is no common theme. Basically, no two people are alike. The symptoms are different. The response to medications is different. The progression is different. So everything really has to be very individualized. And with all this variability, it does raise the question: is Parkinson's disease one disease, or is it potentially a family of closely related diseases? And those are all things that are being researched. So in terms of symptoms, we divide things into basically motor, non-motor, and premotor. So the premotor symptoms are things you can only really see in retrospect, basically. These are things that come on years, maybe even sometimes 15 to 20 years before the tremor starts or before the movements start to become slowed. And they can be things like loss of sense of smell, constipation, acting out your dreams. So a condition called REM sleep behavior disorder, where people start to scream in their sleep and kick and punch and thrash as though they're fighting with somebody while they're asleep. And new mood problems. So new or worsening depression or anxiety can be premotor symptoms of Parkinson's disease. If you're a man in your 40s and you have constipation that's new, that is a risk factor for later going on to develop Parkinson's disease. And one theory is that the pathology that causes Parkinson's disease may start in other parts of the nervous system, such as, for example, the nerves that carry a sense of smell, the nerves that help the gut contract, and then may spread into other parts of the nervous system, manifesting with the motor symptoms. So moving on to the motor, there's these little frequently asked question things. So we'll come back to that. So the motor symptoms that we talk about are tremor, which, as I said, is a resting tremor. And I think I mentioned a little while ago that 30% of people with Parkinson's disease will never have a tremor or not much of a tremor. So just because you don't have a tremor doesn't mean that you can't have Parkinson's disease. And specifically, it's a resting tremor. People who only have an action tremor when they're trying to use their hands that never occurs at rest, that's more likely to be a different disorder. Rigidity, and again, we talk about stiffness, but some people, when they say they're stiff, it's more like things hurt and they have some arthritis. What we mean is when we move, as I said, when we move your limbs around passively, there's some resistance to that. So the muscle tone is increased. And then bradykinesia, which is, again, that slowness of movement. And again, that's really the defining feature of Parkinson's disease, is the bradykinesia. And that can manifest in several ways. So that can manifest as having a soft voice. Hypophonia, we call that. Reduced facial expression. So people tend to blink less. They're not as animated. So people talk about the Parkinson's mask, the mask-like face. The handwriting can get smaller as you go. Your walking slows down. You start to shuffle. Your fine motor control becomes more difficult. People will complain that they have trouble, whisking things when they're cooking or chopping. And really what happens with Parkinson's is that it's hard to sustain a repetitive movement. So if you see your neurologist and they're getting you to do stupid things like this, what we're actually looking for is watching if these movements slow down and get smaller as you go. So that decrement in the amplitude and the decrement in the speed are really the hallmark features of bradykinesia, which we look for. And then postural instability is another thing that can happen. So losing your sense of balance. When we start to fall, we have reflexes that allow us to catch ourselves. We'll either reach out to grab something, we'll take a step back to catch ourselves. And with Parkinson's disease, those reflexes usually are lost. And that's why, it seems cruel when you see us, in the clinic and we, do that thing where we stand behind you and pull you backwards and try to make you fall. That's what we're testing there, is this postural instability. And that's, again, something that we don't expect to see until later in the disease, and can obviously increase the risk of falls significantly. And then the non-motor symptoms. So the list of non-motor symptoms is very long. And the one thing I can say is that I've yet to see anybody who's been so cursed as to experience all of them. So when you read the list of symptoms of Parkinson's disease, it can be pretty overwhelming. It's, but the one, I guess, consolation that I can give is nobody is unlucky enough to get all of these things. The non-motor symptoms tend to be less talked about. It's the iceberg here. Because of that, we tend to focus a lot on the motor symptoms because we're a little bit better at treating those, if I'm being honest. But if you ask people with Parkinson's disease what really is impacting their quality of life, as the disease progresses, it's really these non-motor symptoms that become more prominent and more bothersome. And as the disease progresses, people tend to develop more and more of them. And the reason these happen, so some of these things are dopamine related. So, sometimes when people's dopamine levels are low, they can feel depressed or anxious, for example. But not all of these things are dopamine related. And it turns out that Parkinson's disease is much more complicated than that. And other chemical messengers are affected, other brain networks become affected as the disease progresses. And so not everything is really about dopamine. And that's where some of the limitations of the treatment that we have come in, which you'll hear more about tomorrow with Dr. Raston. So it can be anything. We usually break them down into different categories. So we talk about mood symptoms. So at least half of people with Parkinson's at some point will have problems with their mood. Some studies put this at closer to 90 to 100%. Most commonly, depression and anxiety. Other things that can happen are apathy. So that's just that loss of motivation. You're just not interested. You don't care. You don't want to do anything anymore. You just want to sit and watch television all day. That symptom is usually much more bothersome to people's families than it is to the person themselves. And depression and anxiety can be very common. And, a lot of people have this tendency to think, well, of course you're going to be depressed if you have Parkinson's disease. It's not a walk in the park. But it is actually a symptom of the disease and not just a reaction to the other symptoms of the disease. And they have, studies have been done comparing depression between people with Parkinson's and other equally disabling conditions, things like bad rheumatoid arthritis before there were good treatments where people couldn't really do much with their hands. And it turns out that people with Parkinson's are much more likely to be depressed than people with those equally disabling conditions. It's often overlooked and underreported. And sometimes it can be overinterpreted sometimes because of that sort of flat mask-like face that people get. Sometimes people's families will interpret that as them being depressed because they're not animated. So it can be a little bit tricky to tease this one out a little bit. It can respond well to treatment. So our good friends at the Parkinson Society of BC do have a counseling program that can be quite helpful to some people. And many people find that antidepressant medications can be helpful as well. Dr. Raston, I'm sure we'll talk more about this tomorrow. Apathy, as I said, is common, usually later on, often independent of depression, and is unfortunately can be quite difficult to treat. People can hallucinate with Parkinson's as well, and that can be from the disease itself and can also be a side effect of the medications that we use. Usually with Parkinson's, the hallucinations are visual, seeing insects, seeing people. Most people usually have a sense they're not real and they're not that bothersome, but they can become quite significant. So we always monitor for those over time as well. Sleep disturbances are very common. So we talked a little bit before about REM sleep behavior disorder. People are acting out their dreams. Admittedly, that's usually more of a problem for the person sharing the bed with the person with Parkinson's because they're getting punched and kicked and woken up. But I have people will sometimes fling themselves out of bed and injure themselves with that. So we look at that. Sometimes the Parkinson's symptoms themselves will wake people up overnight. It can be an overactive bladder that wakes you up overnight. A variety of different things can affect sleep. Restless legs, lots of different stuff can contribute. Furthermore, the circadian rhythm or the body clock in Parkinson's that regulates when we get sleepy and when we're awake is also dysregulated in many people with Parkinson's. So one common thing that can happen is, in about an hour from now, as you're digesting your lunch, many people will hit that afternoon wall. That wall with Parkinson's tends to hit people like a freight train, and some people just have to nap and there's no real getting around it. And that's a manifestation of that circadian dysregulation, we call it. Restless leg syndrome, as I said, is more common in people with Parkinson's. If any of you caregivers out there are suffering with restless legs, the reverse is not true. So people with restless legs are not more likely to get Parkinson's, fortunately. And that's in Parkinson's, it's usually a low dopamine symptom. People with Parkinson's are more likely to get obstructive sleep apnea than the general population. And that's even true of people who are tall and skinny. Usually it's people who are shorter and heavier with a short kind of thick neck that we consider at higher risk, but Parkinson's could be anybody. And so we usually recommend, if someone has a lot of sleep trouble, daytime sleepiness, we often recommend screening for sleep apnea. Some people wake through the night, leg cramps, fatigue independent of anything else can be a symptom of Parkinson's disease. Fine motor control becomes harder. It's harder to walk, so you use more energy doing normal stuff like getting dressed and showered. So people will tire more quickly, and then it's just a symptom independent of all of that stuff as well. And we talked about REM sleep behavior disorder. Another category is called autonomic dysfunction. So the autonomic nervous system regulates what we call the housekeeping functions of the body. So your blood pressure, digestion, heart rate, bowel and bladder function, sexual function, that sort of thing. And this part of the nervous system can be dysregulated as well. So constipation happens in at least 70% of people with Parkinson's. Men and women both get sexual dysfunction. Blood pressure regulation, so you can get lightheaded when you stand up because the blood pressure drops when you go from sitting or lying to standing up. Those are really the biggest autonomic changes that we see in Parkinson's disease. Yes, and urinary dysfunction most commonly is frequency and urgency. So you got to go more often, and when you got to go, you got to go right now, which obviously can be a big problem. Cold hands and feet, very common, likely related to the autonomic dysregulation, not dangerous. You're not going to lose your blood circulation to your hands or feet or anything like that. But it's a nuisance for sure, but it's extremely common. Sexual dysfunction, again, very common in both men and women, and usually easily treatable. So other things, pain is common. So Parkinson's disease on its own can cause weird pain, and we don't really understand what the mechanisms behind that are. That pain responds to treatments for Parkinson's disease. So if you take your medication and the pain goes away, and the pain comes back when the medications wear off, if you feel it wear off, that's related to the Parkinson's. If it doesn't do that, then it's not the Parkinson's directly. However, because in Parkinson's, the left side and the right side aren't quite in sync anymore, you start to put different stresses on your body. You're trying to compensate for that. So you're putting different stresses on your knees, your hips, your back, your shoulders. And so people are also more likely to get things like tendonitis, bursitis. It can flare up arthritis that's already there. So there's lots of different things that can contribute. Cognitive changes people are often worried about, understandably so. Unfortunately, most people with Parkinson's disease will eventually develop some degree of cognitive change. If you follow people for 20 years, somewhere along the lines of 80% of people will have cognitive changes. It can occur basically at any time, more likely in older people than younger people. And then as the disease progresses, the longer you've had Parkinson's, the more likely there will be cognitive changes. And the earliest things with Parkinson's are language fluency, finding the words you want, and visuospatial processing. So your brain being able to figure out how far one object is from another. Part of the issue is that some of the cognitive changes you see with Parkinson's are basically the same as the cognitive changes you see with normal aging. And so it can be a little bit disconcerting for people if you read about it. And as we get older, all of us have trouble finding that word or that name. It's on the tip of your tongue, you can't get it. That's normal. multitasking is harder and processing speed slows down. Parkinson's can take all of those and run with them. So it's another thing that we have to screen for over time. And then that is my dog, just to end on a happier note than all of this. It is now 25-1. We have lots of time for any questions. So I am going to go to the chat box here. If any of you have any questions, if I've confused you or want me to clarify anything, just let me know and I'll work through these questions. So number one from Greg, can Parkinson's be mistaken for chronic traumatic encephalopathy? How can you be sure? So chronic traumatic encephalopathy, or CTE, has gotten a lot of interest lately, particularly in professional athletes. Football players in the NFL, and these are people who've taken a lot of hits to the head over time, and they develop dementia, they develop personality changes, sometimes they become aggressive, violent, and they can have Parkinsonism. Usually there, it would be, the only way, again, really to distinguish them 100% would be to do an autopsy, because the findings are a bit different. CTE is a problem with a protein called tau rather than alpha-synuclein. The symptoms are different enough, and you'll often have that history of repeated head trauma. As far as I know, nobody knows, how much head trauma is enough head trauma to cause CTE, but it wouldn't be something that you or I or most people would be exposed to over your life, unless you were a professional athlete, soccer players heading the ball, boxers, that sort of thing, where you're really commonly getting blows to the head. Head trauma, however, does seem to increase the risk of getting Parkinson's disease. But again, the pathology there is different. So they are different diseases, and people with Parkinson's don't have that aggression thrown in. So it's a bit hard, that they're different enough we can usually tell. Okay, and then why are SPECT scans not used in the diagnosis? So the DAT scan is a type of SPECT scan. These are nuclear medicine scans. Other than the DAT scan, the SPECT scans only really give you very non-specific answers. The DAT scan is that one that is newer to Canada, but has been around for a long time. There are, like with every other test, there are false positives and false negatives. There are people who clearly have Parkinson's disease who have normal DAT scans. There are some of the mimics of Parkinson's disease, like progressive supranuclear palsy, multiple system atrophy, also will have abnormal DAT scans. So they don't really help you much at the end of the day. The only times I think that they're that helpful are if you've got somebody, for example, who's had schizophrenia for their entire life, and they've been on an antipsychotic medication to treat their schizophrenia, and now they're 65 and they're starting to show Parkinson-like symptoms. And the question is, are these symptoms, is this person now just getting older and they're developing Parkinson's disease, or are they getting older and their brains are more vulnerable to the side effect of these drugs? So that's one circumstance where a DAT scan might be helpful, but for most people, it doesn't actually give you any useful information whatsoever. Because if, say your DAT scan is normal, but your symptoms are still consistent with Parkinson's disease, we're still going to say you have Parkinson's disease and treat you accordingly. So it's not that helpful. Okay, so next, looking backwards after a PD diagnosis, I recall experiencing some PD symptoms that would come and go. Is it possible that PD could do that? So we talk about with basically all neurodegenerative disorders, we talk about what's called a prodromal phase, and that's where you might be having some of these non-motor symptoms. And you might have symptoms that are just under the surface, so to speak. And if you, add on, as I said before, if you add on any kind of stress, like you're sick, you're sleep deprived, grieving a loss, something like that, that will accentuate any Parkinson's symptoms. Certainly possible that in that prodromal phase, as the symptoms are just below the surface, if you add in something that would accentuate the symptoms, that they would kind of emerge and then regress. So that's certainly plausible. Now, we know the pathology is there for many years before people start to manifest symptoms that we can clearly identify as Parkinson's disease. Okay, so I can consciously turn off my tremor with progressive relaxation meditation that can last all day when I effectively manage my daily stressors. Is this normal? Again, stress will exacerbate the symptoms, and tremor is one that's obviously very noticeable with stress. So for sure, if you're more relaxed, mindfulness has been shown to improve the symptoms of Parkinson's as well. So certainly very plausible. Many people find that if they focus on their tremor, they can suppress it at least for a time as well. And if you activate the muscles a little bit, that often will eliminate the tremor because it's a resting tremor. What can I do to slow the progression? That's a very good question. Dr. Raston will talk about that tomorrow. The most important thing that we know of right now is regular exercise. So that does seem to meaningfully slow disease progression. It also helps with the symptoms in the short term. What exercise should you do? That's also a very good question. And to the best of my knowledge, nobody has yet identified a best exercise. My personal bias is that if there's a best exercise, most of us aren't going to do it unless we like it. And so what I recommend to people is find something that you like and do that for about 30 minutes a day. And that is the best thing that we have. And then for brain health in general, keeping socially active, friends and family, and mentally active. So actively using your brain, reading books, doing word games, puzzles, anything where you're actively engaged is good for brain health and slows brain aging and probably slows neurodegeneration. And there is some emerging evidence that perhaps diet may play a role, particularly a more Mediterranean style diet, by which I mean less animal-based products, more plant-based products, less processed food, more whole foods, whole grains, berries, healthy fats, that sort of thing may slow the progression. And then there are right now something like 30 drugs in various stages of clinical trials that are aimed at treating the actual disease rather than. So stay tuned. Is there something to help with the lack of sleep? There are many things to help with the lack of sleep. It all depends on what the particular problem is. So that's something that's best to talk with your doctor about, because if the main issue with sleep is that you're getting up 6 times a night to use the bathroom, that's very different than if the main thing that interferes with sleep is your tremor. So it really just depends on what the actual problem is. But most things have some things that can help, at least some. The slides, I believe, will be available, and I believe even the recording of this session will be available, but Alana can correct me if I'm wrong. I was given a diagnosis of pre-Parkinson's disease. Can you please provide more information about this? That depends on what they mean. So it might, sometimes what you see is somebody comes in and they're very early and their symptoms are very mild and may not be quite enough to fulfill the diagnostic criteria, but the gut feeling in your doctor is that probably in another year or two you will, and I suppose they might call that pre-Parkinson's disease. Or sometimes people with REM sleep behavior disorder, for example, sometimes people go see the doctor and just get diagnosed with REM sleep behavior disorder and they don't have Parkinson's. We know that more than 90% of people with isolated REM sleep behavior disorder within 15 years are going to go on to develop Parkinson's or one of the mimics of Parkinson's. So that might be what they were referring to, but I'm not exactly sure what the exact circumstances would have been. A lot of the symptoms are known side effects of the medications. Can you explain why this is not spoken about more? So what I have talked about are things that are symptoms of Parkinson's disease itself. And so you are correct that some of them can be side effects of the medication. And, for example, blood pressure dysregulation is a symptom of Parkinson's disease, and that will happen whether you're on medication or not. But most of the medication that we use can make it worse. Similarly with hallucinations, they happen because of Parkinson's, and then the medications can make them worse. So we do talk about that, and sometimes it can be a little bit difficult to know whether it's the drug or the disease. And so what we do is we try to tweak the dose and lower the dose a little bit, see if something gets better. And ultimately, as with any other condition, managing Parkinson's disease is all about managing the benefits from medications with the side effects. And that balance will be a bit different for everybody. And Dr. Raston will talk about that more tomorrow. I'm going to defer all the CBD stuff for tomorrow. Dr. Raston will tell you the same thing that I do, which is basically we don't have any great evidence right now. And anecdotally, I haven't seen really any great responses to CBD from my patients. When does a patient start medication? So again, Dr. Raston will talk about that tomorrow, but it is individualized. Basically, at the end of the day, for most people, they start medication when the symptoms that they're treating are more annoying than taking the treatment, if I'm going to simplify it as much as possible. Or for me, when people are either saying they're falling, they're choking, or they're having to give up work or hobbies that they enjoy doing, that's the time that I try to really encourage people to start medication. Are there any studies that look at individuals who choose not to take prescription medications? Not exactly sure what you're getting at. There are some non-prescription treatments. Again, Dr. Raston will probably mention these. None of them are terribly potent or effective. There is no supplement treatment out there that has shown benefit for Parkinson's disease in humans, unfortunately. And so for right now, the best treatments that we have are really the prescription alternatives, recognizing that they only treat the symptoms of Parkinson's disease. But without prescriptions, people, and there are studies comparing people who've delayed starting prescription medication for various periods of time, and then followed them for long periods of time to see what the outcomes were. And basically the only difference, like 15 years later, is that the people who delayed the onset rated their quality of life as less good in the time that they weren't taking their medications. So there's really no difference in the long-term outcome. If people choose never to take prescription medications, then we know that they will probably not live as long, because the balance is poor, they're more likely to fall, they're more likely to choke, aspirate, get pneumonia, that sort of thing. So the quality of life for people who are unmedicated consistently comes out as not as good as people who are medicated, recognizing that people, particularly on the West Coast, don't particularly like to take medication, which is understandable. I noticed the medication I'm taking is not stopping the trembling of the hand. What should I do? Does it take a few visits to the neurologist to get an exact diagnosis? For the first one, talk to your doctor. Different people respond differently to medications. Tremor is one particular symptom that sometimes takes very high doses of medication to control for some people, that for reasons that aren't entirely clear, but there likely are other treatments that you could try. So talk about those things with your doctor. And yes, in terms of making the diagnosis, like I said, we know we get it wrong sometimes. So neurologists in general, movement disorder neurologists in particular, are always second guessing the diagnosis. So we're trained to look for those red flag features that make us worry that it's not. And so, yes, we sometimes do revise the diagnosis, and sometimes it may be after you've been seeing your doctor for 3, 4, 5 years that you might revise the diagnosis. Because those mimics, like I said, can be completely identical, indistinguishable from Parkinson's disease early on, and then over time they will start to diverge, and it does become more clear over time. But it can be difficult. Wait lists for assessments are 9 to 12 months. Is there any way to get appointments earlier so that we know how to deal with changes that will come? It is true that the wait lists are long, and our clinic now is probably closer to 24 months than 12 months. Most neurologists are comfortable diagnosing Parkinson's disease, and people in many, but not all parts of the province can get in to see a neurologist somewhat sooner. Many general neurologists are offering virtual health appointments for people who live in more remote areas, so that's a potential option as well. But as I mentioned, we estimate 15,000 people with Parkinson's living in British Columbia, and there are 15 movement disorder specialists in British Columbia, and so you can imagine that the resources aren't really there, and that's the same in many places, actually. Even in the US, sometimes it can take a long time to get in to see a movement disorder neurologist. It is a real problem, and it's something actually that I and a bunch of my colleagues are in discussions with Parkinson's Canada about. Is there a different model of care for Parkinson's disease? But it is very challenging. I will freely admit that. We do have the movement disorder neurologists in BC we're on call Monday to Friday, 8 to 5. So if your family doctor is worried about Parkinson's, they can always call one of us and talk through your case, and we can give them some recommendations to try. But access to care is a real barrier for sure, particularly for people who don't live in one of the 5 cities that have a movement disorder specialist in the province. There are times when I feel much better without medication. Yep, so talk to your doctor. If you're worried about your medication, it's always good to talk to your doctor. We always individualize treatment plans. Like I said, no two people are the same, and so there's not really any generic advice that we can give to people for medication. What is functional Parkinson's? Functional disorders, it's a very big topic, but those are it's difficult to summarize it, but basically what we think of functional disorders are more psychologically based symptoms rather than neurologically based symptoms. So they can be a manifestation of suppressed trauma, depression. They're involuntary symptoms that come out. If you think of it, many people, when they're anxious, for example, start to feel nauseated or get palpitations or start to sweat. So people can manifest psychological or psychiatric symptoms physically, and people can have almost any neurological symptom that we consider more to be functional. So the symptoms are just as real and just as disabling, but the treatments are different. Functional Parkinson's is very rare. Of all the different types of movement disorder, functional Parkinsonism is considered to be the most rare. I've only seen it once, but it's uncommon. But these are things that you can distinguish in a doctor's appointment with a physical exam usually. Does PD cause speech problems? Yes. Most commonly, most noticeably, slowed speech. Soft speech, slow as well, but people develop what's called hypophonia, so small speech, and people can start to slur their words at some point as well. There is speech therapy available that can help with that. Speech therapy, I know the Parkinson Society periodically does voice workshops. You can also, I'm sure, just go on YouTube and look for Parkinson voice exercises, and those are helpful. You'll be hearing actually from our speech therapist in one of the upcoming sessions about approaches to voice problems. I was not a professional athlete, but I was in an artillery regiment and subject to lots of concussive blows. Is it worth exploring CTE? Pardon me. The distinction there right now would be largely academic. So there, again, I'm not an expert on CTE, but I don't believe there's any treatment specific to that disease either. Generally, when people have Parkinsonism, regardless of what causes the Parkinsonism, whether it be one of the mimics or what have you, we kind of end up treating it the same at the end of the day because it's symptomatic management right now. So if you're interested, it would be probably finding somebody with a research interest in CTE and trying to enroll in a study there. That would be the best way to proceed with that. Is it common to cough or choke during sleep? Can be, but not totally common. That's something that I would bring up with your doctor as well and make sure there's not some other medical problem intervening, like acid reflux or asthma or something like that. Does exercise also assist the treatment of a mimic of Parkinson's disease? We think so. There's not as much research done with things like progressive supranuclear palsy and whatnot. But we think that exercise helps neurodegeneration in general, whether it be Alzheimer's, Parkinson's, PSP, what have you. So one of the recommendations is still regular exercise. If nothing else, maintaining your physical fitness will improve your overall condition, and helps with maintaining balance and preventing falls and things like that, and helps with your general health. So unfortunately, with Parkinson's or a mimic, you're still allowed to have develop diabetes or heart disease or have a stroke, anything like that. So it's important to maintain your general health as well. Like I said, you still have to floss. So you mentioned that there are about 30 drugs in consideration. How can I learn about them and keep track? So if there are any major breakthroughs, you will hear about it. It will be splashed widely across the media. So don't worry about missing out on a breakthrough. When there are new treatments, we always consider them for the patients that we're seeing. So your doctor should keep up. You can sign up for newsletters through Parkinson's Society of BC, Parkinson's Canada, the Michael J. Fox Foundation. Lots of resources out there for keeping track. We know that unfortunately most drugs in development will fail at some point along the development pipeline, either because of safety issues or because they're not effective. we try to maintain hope, but we hope that of those 30, maybe one or two of them might show some promise and come to market. But stay tuned. It is a bit discouraging. There have been many attempts and many failures along the way, but I'm at least encouraged that there are so many studies happening now, because it wasn't so very long ago that a lot of the big pharma companies were actually divesting themselves of their neuroscience portfolios because everything was failing and they weren't willing to put money in it anymore. And the tables really have turned on that in the last 3 or 4 years. So the research has really picked up again. Okay, so there's a couple questions here about ultrasound. So focused ultrasound is Dr. Raston will, I'm sure, talk about this as well. It's basically an alternative to deep brain stimulation, where they use ultrasound to effectively burn a hole in the brain. So yes, it is being used for tremor and likely will be approved for treatment of Parkinson's disease, probably mostly for people who aren't candidates for deep brain stimulation or other treatments. But I think Dr. Raston will talk about that more tomorrow, so I'll defer for now. Growth hormone therapy affect Parkinson's disease. As I said, there is no treatment right now, whether hormonal supplement, vitamin, that has ever shown benefit for people with Parkinson's disease. Stem cells, lots of things in studies, lots of things that have shown promise in animal models or in cell models where they take neurons in a petri dish and poison them with certain things. But so far, unfortunately, anything that's been tested in humans has not shown any benefit. So it's lots of stuff going on, like I said, but right now exercise is kind of the best thing we've got. I'm going to get another one about ultrasound. Okay. Managed to finish on time.
I actually have a question here that was emailed to me, Dr. Squires. The question is, there are so many symptoms of Parkinson's as newly diagnosed patients. Which ones are important to keep track of so we can report them to our neurologist?
The ones that bother you. Those are the most important things to keep track of. The list of symptoms, like I said, is long. There are treatments for many of them. The treatments are not always as good as we would like them to be, but there are treatments for many of the symptoms of Parkinson's. But at the end of the day, if you have a symptom and it doesn't bother you, there's not necessarily any need to treat it. So I have my list of things that I ask about, the common things like the constipation and the blood pressure regulation, the REM sleep behavior disorder. I really focus on things where there's a safety risk. Constipation can affect how well you absorb your medication, so that's highly relevant to me. So I have my priorities, but your priority really should be the things that are impacting your quality of life. And those are the things that you should focus on when you speak to your doctor. Good question. You can spend all day and you know, at the end of the day, one of the biggest goal of the treatment of Parkinson's disease, until we have meaningful disease modifying treatments, is really to allow you to keep doing the things you like to do for as long as possible. So what I would suggest that you focus on are the things that are getting in the way of doing what you want to do, or that are causing you a nuisance on a regular basis in your life. And keep living your life. Most importantly, keep doing those things that you like to do. Keep engaged, you know, travel, you know, cross off the bucket list things. Yeah, just stay engaged and keep living your life.
Okay, I don't see any more questions. It looks like that is it. Thank you so much for putting on such an informative presentation for us today, Dr. Squires. And thank you for answering all of our questions. And thanks everyone for participating in our workshop and for all of your great questions. Friendly reminder that tomorrow we do have Dr. Raston speaking on PD management and treatment. So she'll be talking about medications, alternative and advanced PD therapies, and non-motor symptoms treatment as well. Have a great afternoon, everyone. Thanks again. Bye now.